Good morning to one and all present here. I'm truly grateful to AIOC for this opportunity. The topic for my study is the repeatability and agreement of the new multimodal imaging platform, Antirion, with IOLMaster 700 and LensStar 900. Biometry is measuring the various dimensions of the eye. The interrelationship between axial length, K readings, corneal thickness, lens thickness are all very crucial to correct the eye power. Biometry is a field that has seen immense evolution in the last 2 decades and progressively advanced from the contact ultrasound technique to immersion biometry to the optical biometry that we use today. At our center, we have the LensStar 900 based on low coherence optical reflectometry, IOLMaster 700 by Carl Zeiss based on SWEPSORT's OCT, and a new device that has been introduced into the market, the Antirion by Heidelberg Engineering based on SWEPSORT's OCT, the wavelength of 1300 nanometers. Antirion is a multimodal imaging platform, all-in-one stop solution for all our cataract and refractive purposes. There are 4 apps that can be utilized. The Cataract app, which takes 4 scans during one measurement and incorporates it into the calculations of biometry for varied IOL power. It is based on an optimized SWEPSORT's OCT technology that allows for accurate measurements and visual confirmation with high-resolution images. The ability to assess the total corneal power leads to a more suitable IOL selection. So where do we stand in our delivery of accurate results in 100% of the cases? So the study objective was to compare the repeatability of ocular biometry measured with the LensStar LS900 and IOLMaster 700 with Antirion to assess the impact of repeatability of ocular biometry on the calculated IOL power. Materials and methods. A study included 127 eyes of 76 patients. Ethics committee approval was obtained and informed consent taken from all the participants. The inclusion criteria was patients with all grades of cataract. The exclusion criteria included patients with media opacity, including corneal opacity and the vitreous hemorrhage, retinal pathology like the posterior staphyloma, CME, or if the patient was unable to sit, or any uncooperative patients. All these patients underwent visual acuity and intraocular pressure measurement. They underwent a thorough anterior segment evaluation. Fundus examination was completed. The participants were subjected to biometric evaluation using the 3 machines, and 3 scans were taken on each machine. These machines were selected in the random order using a table of random numbers. A single trained operator using the same illumination used all the 3 scans. The following were the parameters that we assessed. The formula used for all the calculations was Barrett Universal 2. The IOL power for emetropia was evaluated for the Technis IOL with an A constant of 119.3. A detailed statistical analysis was completed. It was carried out using the MedCal. A p-value of less than 0.05 was considered to be statistically significant. The repeatability was assessed using the 3 parameters, that is within subject standard deviation, test-retest repeatability, and within subject coefficient of variance. The level of agreement between the 3 instruments was evaluated according to the method described by Bland and Altman. The results of the 76 patients that we had, 65% were males and 34% were females. The average age of the population was 62 years. Going to the detailed results, within subject standard deviation showed minimum variation, that is the maximum repeatability in the LensStar. Similarly, even for test-retest repeatability, it was highest for LensStar when compared to Antirion and the IOLMaster. Sorry. Interclass correlation showed a good agreement for all the 3 machines, except for IOLMaster as seen in the orange one. The WTW and the LensStar had a moderate agreement. This is the comparison for IOLMaster. Hence, interclass correlation with each machine showed high repeatability with 3 repeated measurements with all the machines. The IOL power calculation was best for Antirion and slightly low for LensStar and slightly low for Antirion as compared to the other 2 machines. So validation of new machine against any gold standard helps us to establish its usage as a standalone machine, and its repeatability ensures that we understand the extent to which the variability can be attributed to the machine error. It also provides normative data to incorporate for the future. So what was known that IOLMaster and LensStar are well-validated optical biometers, and Antirion is a new addition to the group of optical biometers. So repeatability with Antirion was excellent. Agreement between these biometers and the predicted IOL power indicated an excellent result between the IOLMaster and LensStar. However, the agreement with the predicted IOL power by Antirion was relatively inferior to the other two biometers. The future work can be related to ICL studies using the Antirion, and the future work regarding topography as can be evaluated further. Thank you.
Thank you, doctor. I have a question.
Yes.
Did you have all your patients in the same axial length parameter? Because you a lot of influence of axial length, preoperative axial length, isn't it?
Yes, ma'am.
Because you have not mentioned in that thing. It's very important criteria.
Yes, ma'am. I have already had the table. I have not incorporated here.
But that's a very important thing which we need to.
Yes, ma'am. Axial length will affect the IOL power the most.
Yeah.
So it was all the three machines had a similar range, and it was statistically insignificant.
And which did you consider in your as a gold standard? Because you can say something is reliable only if you have a gold standard. Is there a gold standard, or is it a post-operative final result which becomes the gold standard?
No, ma'am. So you already have done a previous study from a same institute based on IOLMaster and LensStar. So we have taken LensStar as a gold standard because we have, according to our study, we have got the best repeatability with the LensStar machine. So even today, we use LensStar as a gold standard at our institute.